house cleaning duties and get some announcements made. Of course, I think everybody knows that our speaker today will be Dr. William Roberts, who is currently in Dallas, Texas. And we're thankful to Merck, Sharp & Dohme Pharmaceuticals, for making it possible for Dr. Roberts to come and talk with us today. A lot of you will remember a couple of years ago when he was here the last time. We really enjoyed his talk and could look forward to some time for today's talk as well. Our next conference, our May conference, will be on Thursday, May the 1st, and the speaker will be Dr. Thomas Connolly from the University of Arkansas, and we'll be talking on the current treatment of acute myocardial infarction. Dr. Roberts was born in Atlanta, Georgia, and I think it's of note that his father was a professor of medicine at Emory University and was the president of the American Heart Association in 1933. In 1958, Dr. Roberts graduated from Emory University School of Medicine and did his internship in internal medicine residency at Boston City Hospital. Internship at Boston City Hospital and medical residency at Johns Hopkins Hospital and the NIH. Dr. Roberts was trained in anatomic pathology at the NIH and from July 1976 to March 1993. He was chief of the pathology branch at the NIH after that. He has published nearly 1,050 articles in medical journals, authored 17 books, lectured in 1,300 cities throughout the world, one of them being Lake Charles. And for 23 years, he's been program director of the Williamsburg Conference on Heart Disease, held every December in Williamsburg, Virginia. Several of our cardiologists have attended that meeting. He's contributed information on virtually every major cardiovascular condition. Since April of 1993, he's been executive director of the Baylor Cardiovascular Institute at the Baylor University Medical Center in Dallas, Texas. I think most of us will remember Dr. Roberts from his years at the NIH, and I personally can attest to numerous American College of Cardiology talks that he's given through the years that have to be ranked as nothing less than excellent. We are extremely pleased and honored with Dr. Roberts' presence here today and look forward to another interesting and informative talk.
Well, thank you very much, Dr. Turner, for those gracious comments. It's really a pleasure to be back. Since I was here last, I had the opportunity of interviewing Dr. DeBakey for 4 hours, and so he told me a lot about growing up here in Lake Charles, and I'm going to show me his house this afternoon, so I'm very grateful for that. Now, some of the things I'm going to say here, I've said before, so I hope your memory is not perfect. But there are a lot of new things that are happening. What I'm going to try to do here is make the case for cholesterol lowering. This is where I am. I'm at Baylor. There are two Baylors. I'm sure you in Lake Charles here are more familiar with the Baylor in Houston. My job is to convince the cardiovascular community, at least, that there's another Baylor in Dallas. And I've been there 4 years, and I've enjoyed it very much. I went to SMU to college, so it's really good to be back in Texas. The case I'm going to try to make here is the case for lowering our cholesterol levels, and I don't care whether you're 20 years old or 80 years old. It pays big dividends to do that. As far as I'm concerned, it's the best life insurance that any of us can invest in. About half of us in this room will die because we have coronary arteries and other arteries in our vascular system that look like this. They're terribly narrow. If you just look at that person next to you, one of you is going to die because of problems like this. Now, I know the other one might you, but this is the major health problem. That is a disease which has the potential of killing or does kill of any other condition in the Western world. Now, one of the sad things about coronary disease, which is just one of the various forms of atherosclerosis, is that the average age of death in men in this condition is 60. That means that 1/2 of the men never reach age 60. Now, those who reach the hospital are older than 60 because sudden death from coronary disease is mainly a problem of young men. The 40, the 50-year-old young man who dies suddenly. Sudden death later in life is much less frequent. Acute myocardial infarction is far more frequent. But look at this slide. This is from Framingham. Oh, I was pouring a red light at my eyes. That's a bad thing to do. Men, yet shown here in yellow, 45 to 64, just as many heart attacks in that period as women. Just as many heart attacks in that period as in the period after age 65. Now, ladies, you don't, as a rule, get in any trouble till after menopause, but there are just as many deaths from coronary disease in this nation in women as there are in men. You have about a 1 in 9 or 1 in 8 chances of getting cancer of the breast. You have 1 in 2 chances of getting very significant atherosclerosis. So after menopause, beware. I don't remember whether I showed these 6 questions when I talked here before or not. Does anybody remember this? Good.
Must not have shown it.
What's that?
Must not have shown it.
Let me go through a few of these questions. Number 1, how much atherosclerosis is needed in the coronary arteries to cause myocardial ischemia? Well, the answer to that question is a lot. If you look at that, when you try to get that answer at the autopsy table, it's very impressive. When I was at NIH, we used to do this on all the cases we saw at autopsy. And we'd take these 4 major arteries off the heart, the right, the left main, the left anterior descending, and left circumflex, and fix them in formaldehyde and decalcify them and cut them into little bitty 5mm segments and change the blade about 10 times during the preparation so we wouldn't crack a plaque. And then we'd end up with about 55 5mm segments to study, and that's a very expensive thing. I didn't realize how expensive it was till I got the Baylor where I am now, and I have to get money to pay for this if I do it. But it turns out that about 1/3 of the lengths of these arteries, now that's about 9 out of 27 centimeters, are narrowed greater than 75% in cross-sectional area. The units I'm talking about, cross-sectional area, not diameter reduction, the unit of angiography. In other words, if you take a circle divided into 4 quadrants, over 3 of them are obliterated. And I'm talking about obliteration by plaque alone. Plaque alone. Now, all this narrowing, less than 75%, it doesn't make any difference. Because unless you obliterate over 3 of those 4 quadrants, there's no apparent slowing of flow through the artery. So, although every 5mm segment contains plaque, only those that are quite narrow do we get in any trouble. Now, you may say, well, Roberts, you're looking at patients at the autopsy table. Surely these patients walking into my office with chest pain, with angina, or I see in the emergency room with acute myocardial infarction, surely they don't have as much narrowing as you're talking about at autopsy. Folks, I wish that was the case. We have a surgeon, Lonnie Whitten, at Baylor, really an excellent surgeon. And whenever he does a bypass in the right coronary artery, he almost always does an endarterectomy. Now, this is the ostium of one of these endarterectomy specimens of the right. All that's plaque. It continues here. This is posterior descending. Now, what am I trying to say here? Number 1, the whole right coronary artery contains atherosclerotic plaque. The whole thing. This is not a focal disease. It just doesn't hit one area and spare the next. This lousy stuff is everywhere. Now, if we take this endarterectomy specimen, which we've done, and divide it into 5mm segments, and so we can look at segments like this, lo and behold, we see the identical amount of narrowing as in the patients with fatal coronary disease. In other words, there's very little detectable in atherosclerosis in general, we must treat before the first symptom ever occurs. Now, treatment after the first symptom, one can do an awful lot of good, of course. But maximum good has to be started before the first one. These endarterectomy specimens, incidentally, there's a lot of media in these things, this red stuff around here. It's a very impressive procedure. Whether it's useful, we really don't have the data to know. I show this iceberg part simply to point out that the plaques that stick up on an angiogram that you see as a narrow, they are truly the tip of the iceberg. The angiogram, not being critical of that, if I had chest pain, I thought it was myocardial ischemia, I'd want an angiogram. But that picks out the tip of the iceberg. Question 2, what do these atherosclerotic plaques consist of? Now, I'm not talking about plaques in a 10-year-old child, 20-year-old young man or woman. I'm talking about these plaques in a 60-year-old man who's got that myocardial ischemic chest pain, or the 70-year-old woman. It's about 10 years difference in women. What do these plaques consist of? Anybody? Let me ask it another way. What is the dominant component of the atherosclerotic plaques in patients with symptomatic myocardial ischemia? What is the dominant component? Anybody? Cholesterol. Anybody else? Collagen. Anything else? Bone cells. Anything else? Fibrous tissue, which is collagen. So here we have our most common fatal or potentially fatal disease in the Western world, and we have a question: what is the dominant component of these plaques? Well, when I was at NIH, there was this wonderful young lady who worked in my lab. She was a computer expert. She was a cardiologist, a pathologist. She was terrific. And she took all these 5mm sections and took them up on a computer screen, and with a computer pen, you could trace out the various components of the plaques here. Now, what we see in these 5 bars here, the plaques which were small, narrow the lumen 25% or less, and cross-sectional area we'll put in this bar. And these plaques that totally included the lumen or nearly so, we'll put in this bar. Now, what is the dominant component of these atherosclerotic plaques? The answer is fibrous tissue. The yellow represents acellular or dense fibrous tissue. The red represents cellular fibrous tissue. But that makes up about 80% of these plaques. Fibrous tissue, scar tissue, that's almost certainly non-reversible. Even in the little plaques, look at that, virtually entirely fibrous tissue. Now, calcium is shown in the blue. That didn't occur unless the artery was narrowed over 50%. The green represents pultaceous debris or extracellular lipid. This is reversible, experimentally at least. And foam cells shown in the dark, not many foam cells after age 40. Answer to the question: the dominant component of atherosclerotic plaques in patients with either fatal or symptomatic myocardial ischemia is scar tissue. How many direct atherosclerotic risk factors exist? Now, the key word in that, at least for me, is the word direct. What I mean by that is which risk factor or factors do you have to have in order to get atherosclerosis? Do you have to be a cigarette smoker to get atherosclerosis? No, so it's not a direct atherosclerotic risk factor. Do you have to have high blood pressure to get atherosclerosis? No, so it's not a direct atherosclerotic risk factor. Do you have to be a diabetic to get atherosclerosis? No. Do you have to be obese to get atherosclerosis? No. In my view, there's only one direct atherosclerotic risk factor, and that's a total cholesterol level greater than 150 or an LDL greater than 100. Well, you can snicker, I'm sure you are, underneath. Well, everybody who walks in my office has cholesterol levels higher than this. Well, I would suggest, as we all know, that everybody who walks into your office almost in this nation is a candidate for atherosclerosis. But when we're born, 75 milligrams per deciliter. Within 2 weeks of life, it shoots up to about 150, and then it stays about 150 until we graduate from high school, and then it gradually starts going up after that. If we could keep that level, what it was when we were 20 years of age, the health of this nation would skyrocket. Now, that does not mean these things are not important. If your total cholesterol is greater than 150, these things make it worse. They make it act like it's higher than that. High blood pressure, the biggest predisposer to stroke. 60 million Americans with blood pressures greater than 140/90. Obviously, a stroke is worse than a heart attack by far. Dear God, don't let me have a stroke. Got to keep that blood pressure down. Cigarette smoking, you can't be healthy and smoke cigarettes. This slide has to do with the percent of the U.S. population, both men and women, who have total cholesterols greater than 240. Now, 240 is a very high number. And look at this. Men, again, so to go to 35, 44, a higher percent of men, younger age, have these high cholesterol levels. But look at this, ladies. After menopause, after 55, nearly 40% of the women in this country have total cholesterol levels greater than 240. Very, very high number. Now, everybody knows that total cholesterol is not the entire picture. Total cholesterol, as we all know, of course, equals the LDL cholesterol plus the HDL cholesterol plus the triglyceride level divided by 5. Now, this slide from the Framingham study shows that in most of us, the HDL level is about the same all of our lives. We may be marathon runners over here and it'll shoot up, but most of us, it stays the same. And if it's low, it's very hard to get it up there by drugs alone. Really, other things other than drugs are better in raising HDL. Women have about 10 milligrams per deciliter higher levels than men. The LDL, again, until we're about 20 years of age, it's about 100. After age 20, it gradually goes up, and in men it goes up quicker than in women, but after menopause, it's higher in women than in men. It may be that the men with the higher levels are no longer available here to be studied. Now, I think of L as the lousy cholesterol. Of course, we all know that. And the HDL as the healthy cholesterol. Question 4, what factors indicate that cholesterol causes atherosclerosis? I don't use the term multifactorial cause. I think that this cholesterol issue is about the cleanest thing we have in clinical medicine, the connection between cholesterol and atherosclerosis. This all started about 1908 by some Russian physiologists who fed high-fat diets. Well, actually what they did was they fed raw red meat, and then they fed fat, and then they fed pure egg yolks, which is essentially cholesterol, to some certain non-human animals. Now, which animals did they choose? They chose rabbits. You can only produce atherosclerosis in an herbivore. You can give a carnivore, you can give your dog or cat all the fat, all the cholesterol you want, and you cannot produce an atherosclerotic plaque. The only way you can produce an atherosclerotic plaque in a carnivore is to first take out the thyroid gland. Now, if you take a human being and pour continuously saturated fat and cholesterol in that person, can you produce an atherosclerotic plaque? Yes. Now, does that mean we're herbivores or carnivores? How do you like that chicken today? This is our problem. Now, I eat that chicken. You know, this is the challenge we all face. But that is not natural for an herbivore to eat that chicken. You ask the cows if a Holocaust is going on, they'll tell you. Now, the second thing that was done was the biochemists came in and they took these plaques and these arteries and ground them up, and they found cholesterol there. The third thing that happened was Ansel Keys, after World War II, did these 7-nation studies, at least he did these multi-center studies in various nations, and found that people living in some acreages on the planet, like southern Japan or Greece, had a whole lot of atherosclerosis, a lot of symptomatic myocardial ischemia. They didn't, I mean, whereas people living in Finland or the USA, in contrast, had a whole lot. And what he found was that the people that didn't have much atherosclerosis, they had cholesterol levels averaging about 150, and those who had a lot had cholesterols way over 200. So from those international studies, I conclude that atherosclerotic plaques large enough to produce clinical problems occur only in people with total cholesterol levels greater than 150. Now, I'm going to come back to that 150 number because, folks, we are now living in the era that we can reduce our cholesterol levels to the 150 area. We can do it. Now, I think angioplasty is a great procedure. I think coronary bypass operation is a wonderful procedure. My son is a cardiovascular surgeon. He does these bypasses all the time. But I think we can put him out of business. What we have to do is to get our levels low. Now, I'm going to come back to these drugs in a minute. Unless you folks have better willpower than I do, a diet is not going to do it alone. These are other factors. The higher the blood total cholesterol level, the greater the chance of having symptomatic atherosclerotic disease, the greater the chance of dying from it, and the greater the extent of the plaques at autopsy. Lowering blood total cholesterol decreases the chances of fatal and non-fatal atherosclerotic disease. And even if you've got symptomatic atherosclerotic disease, you can reverse these plaques a little bit or decrease progression a great deal by lowering the cholesterol levels. Now, this slide was made from study of the two primary prevention trials done in the 1980s, the Libya Research Clinic and the Helsinki Heart Study. What those trials showed, and these were people who had very high cholesterol levels. They averaged total 262. And what happened is when they lowered the total cholesterol by 10%, that decreased heart attack frequency by 30%. 3 for 1 for your investment. This is the kind of company I want to invest in right there, where you get 3 for 1. Boy, that's nice. That's getting more difficult, obviously. Now, the reverse also occurs. If we increase our total cholesterol by 10%, our chance of having a heart attack triples. Now, we have another study now, which was published in the 1990s. Indeed, in 1996, November, I believe, and that's the CARE study, the West of Scotland study. Now, this also is a primary prevention trial. And the beauty of this trial is that a statin drug was used. This is the only primary prevention trial we have using a statin drug. Now, primary prevention, of course, means that the subjects being studied have no evidence clinically of atherosclerotic disease. Now, these people lived in the west of Scotland. I tell you, they lived badly over there. Their average total cholesterol at the end of this study was 262. And they were put on pravastatin, Pravachol, 40 milligrams a day, half of them, and the other half were placebo group. And during that 5-year period, those people who took the drug had anywhere from a 30 to 45% reduction in all of these variables here compared to the placebo group. These are people who had no evidence of heart disease at the beginning of the study. Now, do these lipid-lowering drugs save money? Look at this. Need for angioplasty and bypass in this primary prevention trial decreased nearly 40%. That's pretty good. Nearly 40% reduction. Death and non-fatal myocardial infarction, all these other things decreased strikingly. And this was a study where there was a 30% dropout rate. A 30% dropout rate. These trials are analyzed by intention to treat method. If there had not been a 30% dropout rate, these numbers here would have been even more impressive. Folks, we'll never have another primary prevention trial. The evidence is overwhelming that cholesterol lowering prevents heart attack. So we've got to accept this data here. Nobody's going to do a primary prevention trial anymore. Now, secondary prevention, this is one of the two major secondary prevention trials we have available, again, using a statin drug. This is a 4S study. The 4S study was published in 1996. The 4 means that 4,444 patients were studied. The S means either it took place in the 5 Scandinavian countries, or the S stands for simvastatin or Zocor. And all of these patients took at least 20 milligrams of simvastatin, and a little over a third, 37%, took 40 milligrams. This study also went on for over 5 years, and look what happened. Total mortality. Now, 80% of these people had already had a heart attack, an acute myocardial infarction. 20% had angina pectoris. So they started taking this cholesterol-lowering drug 6 months after they had had a heart attack. And it went on for 5 years. Total mortality in that 5-year period was 26% less in the group who took Zocor compared to the group who did not. Coronary mortality was decreased 42%. Now, how do you like that? 42%. You have a patient in the coronary care unit with acute myocardial infarction, and you send that patient out. And what do you put that patient on? An aspirin tablet? Great. And that will decrease subsequent heart attack by what? By about 25%. You put that patient on a beta blocker, and that decreases subsequent heart attack about 25%. So look at this as additive. And you put that patient on an ACE inhibitor, and that decreases subsequent heart attack about 20%. You put that patient on a cholesterol-lowering drug, like a statin drug, and it decreases it in this study 42%. And that's just in 5 years. So if you had to take one drug, if you had a heart attack, and left the hospital, the coronary care unit, you could only take one drug, which one would you take? Aspirin. So you'd get a 25% reduction. That's cheap. There's only a penny a day. I'd take a statin drug. I'd make sure I took a statin drug. Somehow I'd get the money to do it. I think I'd cut down that cow that I was eating by about 90%, and we've got plenty of money left over to buy that statin drug. These are really spectacular numbers. Need for angioplasty and bypass decreased 37%. Now that was in the Scandinavian countries. In my hospital, that would be a 60% reduction. A 60% reduction. So it pays big dividends. Now the CARE study is another secondary prevention trial, meaning that all of these patients had had an acute myocardial infarction, which had healed. All of these patients were put on propofol or pravastatin, 40 milligrams a day. Now the interesting thing in this study, in the 4S study, the average total cholesterol was 262, the same as in the West of Scotland study. The average total cholesterol was 262. Now, in the CARE study, the average total cholesterol was 207. All of these patients had had a heart attack, 207. And half of them, for 5 years, were put on propofol or pravastatin, 40 milligrams a day, and the others were put on control. Now look what happened. Fatal myocardial infarction decreased nearly 40%. Coronary artery death and so on decreased 25% or so. Need for bypass and angioplasty decreased nearly 25%. Unstable angina decreased about 10%. And look at this, stroke. Stroke is just tragic. Decreased 26%. The same thing happened in the 4S study. Stroke decreased 30%. And these were patients whose average total cholesterol was 207. If it was over 240, they were not entered into the study. It pays big dividends to get those cholesterol levels lower. Now this combines the 4S study here and the CARE study here. And over on this vertical axis are the coronary artery disease event rates, like new onset angina, unstable angina, new infarct, need for bypass, angioplasty and so on. And these are the cholesterol levels here. Now the 4S study started with a total cholesterol of 262. The goal in that study was to get everybody's cholesterol level less than 200. They didn't quite achieve it for everybody, but they did for a lot of them. Now, as that goes down, the frequency of new atherosclerotic events also decreases. Now, the KIP study started about where the 4S study ended, 207. And here we just continue on down, and heart attack frequency continues to decrease. Now, the point of this slide is if you have a heart attack, if you have unstable angina, if you have congestive heart failure after healing of a myocardial infarction, if you have malignant ventricular arrhythmias associated with severe coronary narrowing, you need to be on one of these cholesterol-lowering drugs. And the lower you get that level, and it doesn't matter where you start on that level, the lower you get it, the greater your reduction in subsequent atherosclerotic events. Now, the post-coronary artery bypass graft trial was published in February of this year, February 1997. This is an interesting study because the subjects being studied were those who had already had a bypass operation. And had a bypass operation anywhere from 1 to 11 years earlier. Their average LDLs varied from 130 to 175, and they had at least one patent saphenous venous graft. Now, they divided the patients into two groups, and both groups were treated with a statin drug, namely lovastatin. You can't have a control group anymore. Now, the average cholesterol in this group, lovastatin was 76 milligrams. Now, they call this moderate treatment group. The average lovastatin was 4 milligrams. In other words, as far as I'm concerned, that's a control group. You just can't call it a control group anymore. You get sued. You can't get it approved in any committees. But at any rate, 4 milligrams a day, 76 milligrams a day. LDL in this group was reduced into the 90s. In this group, it remained in the 30s. Angiographic progression, 27% of the group here, 39% of the group here. New narrowings in grafts, half in this group compared to this group, etc. I'll tell you, I think it is improper to do a coronary bypass operation and send the patient home without a statin drug in their mouth. I think it's improper to have angioplasty and send the patient home without a statin drug in their mouth. I think it's improper to have a patient with acute myocardial infarction and send that patient home without a statin drug in their mouth. It's as far as I'm concerned, it's part of the op note. It's as important as the operation, potentially even more so. Now there have been about 17 trials, angiographic trials, where patients have had their angiogram at baseline and coronary narrowing was demonstrated. And then they had a repeat angiogram 1 year later, 2.5, 4 years later. And in between, half the group was treated with a cholesterol-lowering regime and the other half wasn't. And in all of those trials, no matter what agents were used, one of them was a pure vegetarian diet, one of them was a partial ileal bypass operation. At any rate, there was some change in the degree of narrowing by angiogram. But the most important thing is this one right here. This is a percent event reduction. That is new atherosclerotic events in the treatment group compared to the non-treatment group. Look at this. Reductions 33%, 35%, 80%, 70%, 43%, 89%, 50%. Huge dividends. Huge dividends. No other drugs compete in preventing subsequent events like the statin drugs. Now there is some reversibility of these plaques. I've already mentioned that the dominant component of these plaques is fibrous tissue. But in most of the plaques, and there's a lot of variation from patient to patient, about 10% of the plaque is lipid. Now, if we take a the average total cholesterol in somebody with acute myocardial infarction in this country is averaging about 225. And if we get that 225 down to 150, the evidence is very strong that some of that lipid comes out of there. And if we can shrink that lipid quantity from here to here, that potentially, at least theoretically, can open up the lumen from being narrowed greater than 75% in cross-sectional area to being narrowed less than 75%. And if it's narrowed less than 75%, that theoretically at least is as if there is no narrowing at all. So it pays dividends. Question 5, how can symptomatic atherosclerosis be prevented? It can be prevented by keeping our total cholesterol levels in the 150 area. And if present, how can it be arrested? It can be arrested if we get our high levels down to the 150 area. That's the best news in heart disease today as far as I'm concerned. And that is, if we get our total cholesterols in the 150 area and our LDLs less than 100, there is no evidence, as best I can tell, that new atherosclerotic plaques form. Now the rub is, how can normal cholesterol levels be prevented from rising, and how can elevated levels be lowered to normal? Well, we all know what to do. In order to do that, we've got to decrease our cholesterol levels, or the amount of cholesterol we take in. We've got to decrease the amount of saturated fat we take in. And we've got to decrease, almost certainly, the quantity of total calories we take in. This slide has to do with cholesterol. 3 different groups of investigators, they all show the same thing. As we increase our cholesterol intake, the cholesterol, cholesterol in the blood goes up. Now, it doesn't work perfectly in each individual. This is the way it works in groups of people. Some of us can eat 3 eggs and our cholesterol levels will shoot up. Others of us can eat 3 eggs and they won't change much. So when you're talking with that single individual across from your desk, you don't know whether that person is a diet-responsive person or a non-diet responsive person. Actually, I don't worry so much about cholesterol. As we know, all the cholesterol we take in comes from animals and their products. So if we don't eat animals and their products, we don't take in cholesterol. We only take in about 400, 300, 500 milligrams of the stuff every day, hardly enough to get a calorie out of it. I can tell you that a toothpick weighs 100 milligrams. So none of us take in more than the equivalency of about 5 toothpicks of cholesterol every day. And most of that cholesterol comes from 2 sources. Number 1 are eggs. The visible and non-visible eggs, we eat nearly half of it. And most of the rest of it comes from cows. We call it beef, but it's really bovine muscle. That's 28%. Milk's 9%, cheese 5%, butter's 4%. So if we quit eating cows and quit eating eggs, we have beat the cholesterol issue. Now the big bugaboo is this 3-letter word here, fat. Now the problem with fat is we take in a whole lot of that every day. In the USA, we're now averaging over 140 grams of fat every day. It's actually been an increase in the last 3 years. Let's say we take in 120 grams of fat every day. In general, about 1/3 of that is saturated. Now, how does saturated fat cause our cholesterol levels to go up? I tell you, that's been a very difficult question for me to get the answer from. But the best I can tell is when that saturated fat enters our bodies, it's converted into cholesterol. Now, none of us should take in over 75 grams of fat every day. I can tell you that a deck of cards weighs 75 grams. We'd all be better off if we didn't take in over 50 grams every day. Now, every fat that we eat has all 3 components in them. The saturated component, the monounsaturated, and the polyunsaturated. Now, the saturated raise our cholesterol levels, or they at least almost always. The monounsaturated, the poly, either lower our cholesterol levels or they have a neutral effect. But the question is, which is the dominant component? And these over here, where saturated is so high, those are the ones we want to avoid. Palm kernel oil, 86%, butterfat, 66% saturated. All that is converted into cholesterol. Now, there's some evidence that monounsaturated is better for us than polyunsaturated. monounsaturated. Look at olive oil, 77% monounsaturated. Olive oil is great. Where olive oil is eaten in great quantity, the frequency of atherosclerosis is very low. If you're going to have to eat an egg, cook it in olive oil. Now, if you want to get a good grease job quickly, there's no better place than the fast food chain. Now, these two people, Michael Jacobson and Sarah Frishno, went around, they've done this twice now, to the 15 top fast food chains. And they tried to determine the ingredients of these various products. Well, the champ at the moment is Carl's Jr. Double Western Bacon Cheeseburger. Folks, that's over 1,000 calories right there. And if you take that sucker and squeeze it real hard, you come up with a 14 or 15 teaspoons of fat in that single hamburger. Now this word here is sodium. It's not salt, it's sodium chloride. None of us should take in over 1,800 milligrams of sodium every day. We'd all be better off if we took in less than a gram, less than 100 milligrams, 1,000 milligrams. But you can get 1,800, the daily value, right there in old Carl's Jr. No problem. I'll have the half-pound double deluxe bacon steer burger, please. You want chemotherapy with that? I think that's the truth. There was a book up here in the USA about 5 or so years ago, and the person who wrote it asked the question, what do we consume in the USA every 24 hours? Well, about 815 billion calories of food, roughly 200 billion more than we need. Now, those 200 billion every day would feed the whole country of Mexico. In 1990, folks, we reached 60%. 3 out of every 5 adults in the USA are overweight. 3 out of every 5. Now, in the state of Louisiana and in the state of Texas, I suspect it's even higher than that. And the closer you get to New Orleans, the higher it goes. Now, we kill about 100,000 cows in the U.S. every day, yielding 60 million pounds of red meat. As you know, we've got about 265 million people in the USA and 100 million cows. And every day we kill 100,000. And we do it differently in the USA and Canada than in the rest of the world. As you know, we bring them into these feedlots, and they're feeding them for their last 5 to 6 months of life. And there we feed them 20, 25 pounds of grain and soybean every day. And why do we do that? We do that, of course, to make them fat. Because when they're fat, they taste better. And then we kill them, and then they kill us. And that's the way the system works. And in addition to that, we kill about 250,000 hogs every day. And some of them live their whole life on planet Earth without ever touching planet Earth. And we eat about 4 million pounds of bacon every day. Bacon is 85% of pure fat. Now, if you don't know what it is, make a hot dog out of it. We eat about 47 million of them every day. McDonald's puts 2,500 cows on their tables every day. Dairy cows yield 47 million gallons of milk every day. We eat 170 million eggs every day. And folks, if you're a chicken, don't wander into the USA. This is now of the 19 million chickens killed in the USA every day. And we just play a good part in that today. We eat 50 million pounds of sugar every day, an average of 21 teaspoons apiece. Can you imagine waking up in the morning looking at your bedside table, seeing 21 teaspoons of sugar there? These processed foods we all eat are loaded with sugar, and they're loaded with salt. We drink about 16 million gallons of beer and ale every day, and 1.5 million gallons of hard liquor every day, enough to make 26 million Americans thoroughly drunk every day. We still smoke about 85 million packs a day. 3,000 to 4,000 teenagers take up smoking every day. I like William Collins' statement. He says the carnivore animal has almost an unlimited capacity to handle saturated fats and cholesterol, whereas the vegetarian and herbivorous animals have a very restricted capacity to handle these food components. It is virtually impossible to produce atherosclerosis in the dog, even when 100 grams of cholesterol, and that's 200 times the average daily intake for humans in the USA, plus a quarter pound of butter fat are added to his meat ration, in contrast. adding only 2 grams of cholesterol daily to a rabbit's chow for 2 months produces striking fatty changes in its arterial wall. Now, are we more like the rabbit or more like the dog? Let's take a peek at that. Now, when you look down at your appendages, do you see claws or do you see hands that we're supposed to be using to gather these fruits and vegetables we're supposed to be eating? Now, there are those who argue, well, these teeth in the front of our mouth are sharp, so we're really omnivores, but most of our teeth are flat or for grinding. Now, the intestinal tract of a dog or cat is very short. You know, you give them something to eat, they got to go outside in a few minutes. But the intestinal tract of a human being, our small intestine alone, if you stretch it a little bit over this podium, over to that wall there, very long, plenty of time to extract all those ingredients from those fruits and vegetables. Now, when you cool your body, you pant like a dog or you sweat. When you drink water, you lap it like you're a cat or do you sip it? I don't know any human beings that make their own vitamin C. Carnivores do. We, of course, obtain it from our diet. Folks, I think we're one of these carnivores, and we certainly conduct our lives as if we were. But I would suggest, as have many others, that basically, fundamentally, we're in this group over here. And I'm absolutely convinced that the health of this nation will not improve unless we move more to the right. Nuclear cardiology is not going to improve our heart. We pull our chair up to that table 21 times a week. That's when we are determining our health. We are making a statement. Atherosclerosis is clearly hereditary in only 1 out of 500 people. 1 out of 500. We determine whether we get it or not. Now, there are a lot of articles in the last 30 years on diseases that pure vegetarians don't get. Actually, as best I can tell, this was started by a surgeon. The lymphoma of Burkitt in Africa, in Kampala, Uganda. He went over there as a general surgeon right after World War II, and after he'd been there a while, noted that, by golly, he wasn't operating on anybody for appendicitis. He wasn't seeing any diverticulosis. People didn't come in complaining of constipation or hemorrhoids. And he started looking at this further and found, lo and behold, very little atherosclerosis. It turned out in his population there was a lot of high blood pressure, but in general, in pure vegetarian societies, there's very little high blood pressure. For cancer of the breast, maybe 4 or 5% of it is hereditary. But in pure vegetarian societies, it's very uncommon. Cancer of colon, very uncommon. Much higher frequency of prostate gland cancer in heavy meat eaters compared to light meat eaters. Diabetes after age 50, very uncommon in pure vegetarian society. No gallstones, no kidney stones. Look at this, ladies, osteoporosis. It's estimated in this nation by age 65, the average woman has lost 35% of her skeleton. 35%. Why? Not getting enough estrogen. There are some people who believe that we take in too much protein. The more protein we take in from meat, for example, the more calcium we lose in the urine. During World War II, certainly, there was not much red meat available, and not much butter, and not much cheese. And what happened to a cardiovascular death rate in World War II? 1939, 1945. Well, in Sweden, boom, it fell. In Finland, boom, it fell. In Norway, boom, it fell. In the USA, it just kept on going. Can we change our health? Of course we can change our health. This has to do with body weight and when we die. The authors call it mortality ratio, based on 20 studies from the Harvard School of Public Health. Whether you're a man or whether you're a woman, the more we weigh, the sooner we die. And we can all point out the Winston Churchills on the planet, but in groups of people, the more we weigh, the sooner we die. Now this slide is not really about overweight. It's about obesity. I've already mentioned in this country that by age, that 60% of adults in this country, 18 and over, are overweight. I read an article recently that showed that peak fitness in teenagers now is age 14. Nearly 50% of teenagers in this country now are overweight. This has to do with obesity. Obesity being defined as 20% or more over ideal body weight. And what do we see here? Black women in this nation over 40% are not just overweight, but obese. 25% of black men, 25% of white women, 25% of white men. Obese, over 25%. No nation in history of planet Earth has the problem of body weight that we have in this nation. The Europeans come over here, the Japanese come over here, they laugh at us. They look around, my God, what are they doing? When I was at NIH, we had a lot of foreign visitors. Every time one would walk into my office, I'd ask them, what strikes you most about Americans? The number one answer I got is how many fat people we have in this country. It is a problem we all have to face. Now this slide has to do with cancer of the breast. And this is the frequency of cancer of the breast on the left column. That is death from cancer of the breast. And on the horizontal axis here is the fat consumed average by adults in these various nations. Now here we are, USA right there. We are over 140 grams of fat consumed every day, and we have one of the highest frequencies of cancer of the breast in the world. Now the point I show this slide is that this could just as easily be cancer of the breast, the colon. It could just as easily be systemic hypertension. And of course, it could just as easily be atherosclerosis. The lower the quantity of fat consumed by any society, the lower the frequency of our two most common cardiovascular conditions and two of our three most common cancers. Can we change our health? Of course we can. Now, we're not going to change our health by diet alone unless you have enormous discipline, more discipline than I do. I was a pure vegetarian for about 18 months. It's tough. After that, until recent months actually, I ate fish, and that was it. I still don't eat cows, I don't eat pigs. I do eat chicken periodically, but mainly I eat fish. And I don't eat flesh at more than about 5 of 21 meals a week. And I think that we've got to get away from the idea that we've got to have flesh at every one of our meals. Now, the most commonly prescribed diet by American physicians is a 30% of calories from fat. Now, let's say you're eating 40% of calories from fat and you go down to here. What does that do to the total cholesterol level? On the average, this is Huntinghack's study. It's a beautiful study published April 1993. It lowers our total cholesterol by 5%. Big deal. Now, it lowers the LDL by 5% on the average. Big deal. So when you go out of the hospital after a heart attack, you can either have a choice of taking the lowest dose of any of these statin drugs and get a 27% reduction in LDL, or you can go on this 30% of calories from fat diet and get a 5% reduction. Now, which do you want for you? And which do you want for your patients? I'll take the 27% on the drug, and then if you get the diet down there, you can give them an additional 5%. Now, for diet to really significantly lower cholesterol, we have to get it down here to about 20% of calories from fat. That's tough doing in this country. That's tough doing. Now, these are the cholesterol-lowering drugs that are available today. And I think these statin drugs, anyway, are magical drugs. The statin drugs are to atherosclerosis what penicillin was to infectious disease. We have a group of drugs that can indeed have an enormous impact on atherosclerosis in this nation. And what happens? We're not using them enough. When penicillin came out, doctors clamored for it. The pharmaceutical industry couldn't make it in sufficient quantities. We had a penicillin czar, Chester Keeper from Boston, who determined every civilian in this country in World War II who got penicillin. Now we have these statin drugs, and only about 3 million Americans are on statin drugs. We have 40 million Americans with total cholesterol levels greater than 240. We have probably 15 million Americans with symptomatic coronary disease, carotid arterial disease, cerebrovascular disease, peripheral vascular disease, abdominal aortic aneurysm, and in my view, every one of them needs to be on one of these drugs. Now this slide I laid out, and it took me about a year and a half to come to grips with the dosages of these various statin drugs. Now, A stands for atorvastatin or Lipitor. That's the latest one that's come out. S stands for simvastatin or Zocor. L for lovastatin or Mevacor. P for pravastatin or Pravachol. And F for fluvastatin or Lescol. Less really means less. This is the least effective one. Now, at these doses, every one of these drugs will reduce LDL by 27%. 27%. Secondly, they will produce lower total cholesterol about 22%. Now, what does 22% mean? It means that if you have a total cholesterol of 200, that will lower it to less than 160. That ain't bad. Now, the side effects, that is liver enzyme greater than 3 times the upper limit of normal, is 0.25%. That means 1 out of 400 people have liver enzyme elevation. Now, that's the same as placebo. In other words, at these doses, it is a totally non-toxic drug. A very important concept. Very important. The toxicity here is atherosclerosis. The toxicity is not one of these drugs. I was talking to the fellow who runs a lipid clinic at Hopkins the other day, and lo and behold, he told me he had never seen a patient at Hopkins who was on a statin drug whose liver enzymes went up greater than 3 times the upper limit of normal on 2 separate occasions. Never. Now, this dose, when you double the dose of these statin drugs, and incidentally, atorvastatin, the beginning dose is 10 milligrams. It's not available in 5. When you double the doses of these, you increase the LDL lowering by 7%. This is the rule of 7. So every time you double the dosage, you increase the lowering by 7%, 7%, 7%, 7%. The rule of 7. If you remember 27, then you can remember the rule of 7. Now, total cholesterol is the rule of 5. At these lower doses, you lower LDL total cholesterol by 22%. Every time you double the dose, you lower it 5 more percent. 22, 27, 32, 37, and 42%. Now, every time you double the dose, you double the frequency of enzyme elevation greater than 3 times the upper limit of normal. So at this dose, the middle dose here, you get 1 out of 200 people get a liver enzyme elevation. If you take them off the drug, it goes right back down. There's been no evidence of permanent damage. 40 milligrams of Zocor is the upper limit at the moment. That's equivalent to 20 milligrams of atorvastatin, 80 milligrams of lovastatin, 80 of pravastatin. And that gives you 1% of the patients who get enzyme elevation greater than 3 times the upper limit of normal. The charge, incidentally, by Merck of a 20 milligram tablet and a 40 milligram tablet are the same. So you can get 40 milligrams here for the same cost you get 20. Atorvastatin will go all the way up to 80 milligrams. Merck, probably next year, will get approval for their 80 milligram and 160 milligram tablet. In other words, these drugs are so safe, you can go all the way up. Now, it looks like it levels off at 2% in liver enzyme elevation greater than 3 times the upper limit of normal. So the toxicity is no greater than 2 out of 100 people. Who should be on these drugs? This is the Adult Treatment Panel's recommendation. I disagree with it. If you've had a heart attack and your LDL is greater than 130, the recommendation is to get it under 130. Now, it seems to me that if it's good to get your LDL less than 100 after a heart attack, almost certainly it's good to get your LDL less than 100 before a heart attack. And then the chances are you won't have a heart attack. So I believe in using these drugs much more vigorously than this. The CEO of our hospital sent me a fellow on the board the other day, and the fellow came in, he said, "Doctor, he wanted to know whether he ought to be on one of these cholesterol-lowering drugs." Well, this fellow is 48 years old. He's one of the outstanding citizens in the city of Dallas. He has a total cholesterol of 310. His LDL was 207. His HDL actually was 68. And his triglycerides were 193. And he had no evidence of heart disease, no familial evidence of heart disease. His blood pressure was normal. He was a non-smoker, and he was an exerciser. Well, he looked clearly to me like he had familial hypercholesterolemia. Now, his doctor wanted to have him have an ultra-fast CT, and then if it showed calcium, then he would put him on the cholesterol-lowering drug. I told him that it was my view that he ought to save the money from that test and buy one of these statin drugs. I think we should use them a lot more liberally if we're going to change the health of this nation. I show this, I believe this slide has to do with triglycerides. No, these are the various doses here of simvastatin, actually, at 10, 20, and 40. And you see how you get greater reduction with greater dose. In my view, anybody with symptomatic atherosclerosis ought to be on these drugs. Anybody with familial hypercholesterolemia ought to be on the drugs, and maybe a lot of people in between. These drugs are also useful for triglyceride levels. The higher the triglyceride level, the greater the effect on triglycerides. I believe in using the statin drugs to maximum dose in somebody with elevated triglyceride level and not use Lopid or gemfibrozil or nicotinic acid to lower the triglyceride levels. Now, this is something that came out last month. I'm almost done here. This is a wonderful piece of information. These statin drugs are anti-myocardial ischemic. This was a study published in Circulation last month. They took 40 patients. They took 40 patients who had angina, and by 48-hour Holter monitor, they had ST segment changes. And then half of the group they put on lovastatin only 20 milligrams a day. And then they repeated the Holter monitor 4 or 6 months later. And what did they find? In the treatment group, 13 of the 20 patients lost their ST segment changes on Holter, and all but 2 of them, they decreased. Whereas in the placebo group, only 2 of 20 lost it, and most didn't. These are coronary arteries at sites of maximal narrowing in a woman who was 103 years of age. I show this simply to point out that atherosclerosis is not a degenerative disease. We don't have it just because we get older. We are the degenerates, I'm afraid, not the disease. Look at this. This is the left main in this 103-year-old lady. This left anterior descending at sites of maximal narrowing. This poor woman was run over by an automobile. Folks, I'm going to end it there, but at any rate, try to keep your total cholesterol down to 150, and then you don't have to worry about all this. Try to keep that body weight ideal. It's very hard. I got a bad hip, so it makes it hard for me to do that. But I recommend that you weigh every day. Every morning I wake up, I weigh. And if I'm over my number, I just don't eat that day. But I think it's important that we keep our body weight what it ought to be, and our health, I think, will improve a great deal. Thank you very much.